So I'll be covering it into this heading. I'll be giving the introduction followed by what we have done, the survey of teachers and the students. So what do we expect from a resident? All of us have been residents, all of us have gone through the phase of teaching also. So out of a resident, what we want is safety. Basically, a resident should make safe diagnosis. We want safety from him in the management of whatever patients he sees. Then what we want is basically basic surgical skills and basic handling of emergencies. And what primarily we want out of him is not the hi-fi things. What we want is safety of the patients. So that is what expectation, what we expect from a resident during his residency and immediately post his residency also. So what we did was we surveyed a few teachers, which included 32 PG teachers from 9 institutions, both MS and DNB, and it was a pan-India survey. And this is what we found. See, what they said was most of the students were reading standard textbooks, but they were reading a lot of things online also, which was not authenticated. Second thing is they were reading a lot of notes from their seniors and hands-on notes from passed on from nets. There was lack of authentic references. This was also very, very common. I think most of us have gone through this phase also. There was a plethora of knowledge which is available in the internet, but there is a lot of confusion also. So this is the first thing which came out of this survey from the PG teachers or the examiners. Second thing is, most of the residents were lacking in diagnosing common disorders. They were lacking in doing refraction and giving spectacle prescription, which was because there was over reliance on basically optometrists in most of the centers. Basic diagnostic skills were lacking, and there was over reliance on equipment. I'll give you an example. Most of our residents are very happy saying there is a macular edema, but clinically they cannot diagnose. It is basically OCT diagnosis. So the over reliance of equipment was very glaring once you talk to the examiners. And if we have examiners here, they will vouch for this fact also. There was a poor knowledge of medicines. All of us will agree, most of the residents don't know the generic names also. They all know the brand names, but generic names are lacking. Drug interactions, they are not aware. Exact dosages, they are not aware of. So this is again one factor came up. And second thing, most of the examiners they came up was there was no exposure to basic equipments and lasers. This was the problem which came up once we talked to the examiners. Then what most examiners wanted was basic handling of trauma, corneal ulcer and chemical injuries. So these things are again came up while this survey was being done. And what most of the examiners they wanted out of their residents was that they should know basic cataract surgery, corneal suturing. And once you know corneal suturing, and they should be knowing how to convert a case in case there is a complication, phacoemulsification. Hence, suturing was very, very important, and emergency managements. So once we surveyed the residents, which were 48 PG residents in 9 institutions, again pan India, both MS and DNB. What they wanted was they wanted guidance from faculty. They wanted somebody to tell them, okay, read from one or two standard textbooks. They didn't want a confusion in the textbooks. Then they wanted less of lectures, more of interactive sessions during the residency. What the residents wanted was daily discussion, review of cases, because this is what was lacking. Most of the times residents are being used as mules in most of the institutions. They are doing the bum job, but they don't get any teaching, they don't get any experience. What they wanted was more faculty lectures and exposure to PG training programs all over the countryside, which are happening by various institutions. The expectations was having skill lab in the place where they were doing the residency, and on-job monitoring as well as mentoring by faculty and seniors, which was lacking. Emergencies, what point came up was that most of the times the residents were handling the emergencies themselves without any knowledge, without any guidance from faculty. So they wanted more involvement of faculties and more hands-on surgeries in emergencies where faculty was available. This is a pan-India problem when emergencies are handled by purely residents and nobody else. And they wanted exposure to wet lab simulators and conferences. This was again a wish list by the by both teachers. They wanted this thing as well as the residents. So what we did was we standardized the training program. I think most of institutions have it, but it is just a simple gist of how we did it. the PG was divided into 6 semesters. The mentors were detailed. So basically, every PG was under few senior residents, and they were mentoring them, and then faculty on top. And then the program was divided into lectures, OPD, OT training, and evening trainings. So basically, what we did was first semester, nothing else except the resident was exposed to only basic research methodology and thesis protocol. Theory, we wanted only books like Elkington, Parson, Khurana, basic specialities. They were exposed to PG in OPD only for refraction, basic OPD procedures, and primary case workup only. And lectures were basically taken by them for only symptomatology and art, physio, optics, and drugs only, nothing else during the first semester. And OT, the residents were coming in the morning, they were arranging the trolleys, setting up the machines. This is again an important part of OT management. If you don't know how to set a machine, I think you should not be doing surgery. The second thing was they exposed to skills lab, simulator, and evening rounds only, fundus and fundus examination, slit lamp examination they were exposed to, and there were 2 exams taken at 3-monthly interval. So again, in the next sessions, the next speakers will talk about how to mentor and how to have this on-job monitoring by examinations. Then second and third semesters, so basically these guys were collecting data for their thesis. Theory, the level was increased to Shields, Yanov, and Kansky. And OPD, they were under supervision of faculty, and they were again exposed to initial examination, differential diagnosis, and they were exposed to OPD lasers also. And now this was the time when we introduced system-wise ocular diseases and management in lectures. And OT, again, they were first assistants now, and they were exposed to surgeries like pterygium, conventional ECC, and SICS. I think most of us will agree this is a very important step. Rather than straight away exposing a resident to a phacoemulsification, he should know how to do suturing. He should know how to do conventional surgery also, because it helps once he goes outside and he is working alone. Then they were exposed to skills lab, simulators, and evening round. They were on independent call duty under supervision of SR. Then they were exposed to gonioscopies, visual field topography, OCT. All this was done in the evening so that they have time in discussing these things with their mentors. And system, again, examinations. Now we had examination in next 2 semesters. This was system-wise monthly examination. So 1 month you had examination on cornea and accordingly like that, something like that. 4th and 5th semester is a time when they do their data analysis and for thesis and submission. This time now the level was increased to subspecialty books. This is the time again they were doing independent OPDs with SR and all OPD procedures with SRs. And this was the time when they were exposed to subspecialty clinical rotation also. Never before that. Before that it was all general ophthalmology. And this is the time when they do lectures where they have only case presentation and general club and nothing else. And OT, they were exposed to phacoemulsification. Apart from that, lid and corneal trauma repair was also in their curriculum. This is very important. This is what they should be exposed to. Skills lab simulator continue. And evening rounds, now this is the time they can be put on independent call duty and they can mentor their juniors also. And they can have case discussions with their faculty on call. Examinations, again, this is the time when we expose them to 3 monthly examinations on university pattern now. So this is just a gradual introduction into examination pattern also. In the 6th semester, this is the time when we do topic-wise review and review of last 10-year paper. This is very important. Now this is the time they should get exposed to the papers also. This is the time in OPD they do independent OPD and do all OPD procedures independently, and subspecialty rotation continues. And in lectures only case presentation, table viva, drugs and instruments, because this is the time we expose them how to give an exam pattern. OT is the time if they want to come to the OT at least for the first 3 to 4 months of the semester. That is the time they can do complicated phacoemulsification, lid cornea trauma repairs, management of complications, and emergency surgeries under supervision. And in evenings only review of cases and discussions for them as they are mentoring their juniors also. And then we can introduce to them 2 monthly examination university pattern, both theory and practical. This is how you gradually introduce them to both the clinical aspect also as well as the examination aspect also. And it is important to have a SWOT analysis in the end where you can check their strengths, what are their strengths, what are their weaknesses, give them opportunities in skills lab and simulators. And as discussed earlier, the threats are always the basic concept. Most of the residents are lacking in the basic concept. That is where I think we should give more emphasis on. So corrective steps were based on SWOT analysis. If they had weak surgical skills, more time in skills labs or simulators. So if you have poor theory or clinical results in the SWOT analysis, give them more evening sessions with the mentors. So in conclusion, at least for the introduction part, what is important is having standardized protocols for residency training, have checklists, gradually upgrade their skills, and most important thing is constant mentoring. As it is said, our excellence is an art won by training and habituation. We are what we do repeatedly. So excellence is nothing but it is not an act, it is basically a habit. So repeated things are most important. So this is how I end.